Okay, so we're really excited about this bit of work. We're quite excited about quite a few things at the moment, actually, because 2 years worth of work basically is all sort of coming to fruition at the moment, and this is a biggie, and we really hope this is going to make a massive difference. One, to you, but obviously most importantly to your patients. But some simple changes we hope will make quite a difference. So why have we devised a new pathway? Well, the old ones were really quite old. So we're probably going back 8 years now since the first venous leg ulcer pathways were developed, and they really did need updating. And what we were hearing from you guys was that there were lots of pieces of paper. So there was a standard venous leg ulcer, there was a complex venous leg ulcer, there was a pathway to help you work out which pathway to be on. Then there was a mixed etiology pathway and a decision tool, and it was all a little bit complicated as to how to follow things. So we wanted to make things quicker, simpler and easier so that you could actually use them. Also, there's been some new evidence and some new, so international evidence, a new national guidance, and we obviously needed to incorporate that. As I said, we really wanted to improve patient outcomes. Things aren't good out there for a variety of reasons. Things aren't good for you guys. You just haven't got enough time to be able to do the jobs that you need to do. So we want to make it lean. We want to make it give the best possible chance of success, because this really is one of those things. A leg ulcer, you have to invest to save. If you don't do the do or the necessary along the way, they get into really complex chronic wounds that take forever to get healed and consume huge amounts of your time. So we're trying to make it as lean as possible to reduce demand through getting best success. I keep calling this pathway completely different things. So the other pathways were leg ulcer pathways. We're calling this a lower limb wound pathway. I'm sure everybody will still refer to it as the leg ulcer pathway, but the wound bit is we've made a conscious decision to call it a lower limb wound pathway, and that will become evident in a little while. So what's going on? Well, nationally, not just locally. We know what's going on locally and how hard it is for you guys and some of the decisions that you've had to make to cope with really appalling sort of staffing levels, your red escalations, reducing the number of visits, etc., etc. So we know it's not good locally, but it's absolutely not good nationally. And even before COVID came along, leg ulcer care, it has not been good, and for many reasons. And it's because things weren't good that a whole bunch of different professions involved in the lower limb got together to create the Legs Matter campaign, basically to shout, loud to the powers that be that we're not doing well and things need to improve. So some of the evidence behind why they think that we're not doing well, all sorts of different bits of research have discovered that over half the patients on district nursing caseloads are estimated to have a lymphedema or chronic edema with no access to specialists. How many people do you manage to get into the lymphedema clinic? So you're left dealing with something that can be fairly complex. 30% of wounds lack a proper diagnosis, which prevents the identification of a suitable treatment plan. That's not great. You're not going to get good outcomes if you haven't even worked out what the underlying problem is, are you? Every year, well over half of all chronic wounds don't heal, which is a really tragic statistics if you happen to have one of these. If you have got a lower limb ulceration, there's lots of evidence to show that the quality of your life is markedly reduced. So it's a pretty miserable thing to have. Scarily, they found that clinical commissioning policies were not even compliant with NICE guidance. So, for example, NICE is saying that, and there's great evidence around this, that if you've got a venous leg ulcer, you should be automatically referred to the vascular service for venous duplex scans with a view to sclerotherapy, because that has a good chance of reducing your healing rate. And in fact, the lower limb sequin that we're being looked at the moment asks to see if we have done that and is requiring us to do that. But the local pathways don't actually support that at the moment. And there's all sorts of things nationally that aren't supported, but local pathways that are advised by NICE and all the evidence. And a really sad statistic is that the number of amputations in non-diabetic patients is rising. Something that I've learned more firmly in my mind since the Legs Matter campaign has been out, that any wound on a foot is a high risk foot. And regardless of whether they're a diabetic or not, if that wound isn't healed, I mean, if you stub your toe and it bleeds and it heals, that doesn't need to go to podiatry. But if you have a patient that's got a wound below the malleolus, even if they're not diabetic, that patient should be seen by podiatry because it's a high risk foot, and the number of amputations is rising. So plenty of evidence that we're not managing this cohort of people well. There we go. So what are the key bits of evidence that we're trying to incorporate into this pathway? Well, there's two things really. The main one is the National Wound Care Strategy lower limb recommendations. So NHS England commissioned the National Wound Care Strategy to look at some key areas in the knowledge that we're not doing well. And the lower limb pathway has been looking at what we need to do to improve care. And so they've come up with some recommendations and we wanted to incorporate those. There's some key things on there. The revolutionary recommendation that we're going to focus on in this session is about assessing a limb for certain red flags to see if there's something that's urgent that needs referring somewhere else. And actually, if there's no red flag present, then that person can go into 20 millimeters of mercury immediately as part of the strategy of trying to prevent wounds getting chronic before you've had a chance to assess them. Okay, so the lower limb, let me just check that we're onto there. Yeah, the lower limb wound pathway. This is the top part of the document, what it looks like. So this document is already loaded onto our website. If you go onto the lower limb tab, unsurprisingly, and scroll down, you'll find the lower limb wound pathway. Open that and this pathway is in there. So basically this pathway starts at the very first time you see a wound on a leg. So somebody could have said, oh, I've fallen over, I've had a skin tear, or suddenly my leg started weeping. You're starting this pathway immediately. And that's why we've called it a wound pathway and not an ulcer pathway, because if we're splitting hairs, an ulcer is a chronic wound that's not healing. And so we don't want to have a leg ulcer pathway where the implication might be that it's only when the wound isn't healed that you start it. This pathway is to be started right at the beginning, whether you anticipate you're going to have problems or not. This is what you will be doing. OK, so the first thing that you're going to do is you're going to assess for these red flags, and there are 5 of them. This is the pink box that you can see there. So the 5 things that you are looking at are for cellulitis. And there's a video about doing this assessment, so I'm not going into too much detail now. So cellulitis of the leg or the foot, suspected sepsis, acute or chronic limb-threatening ischemia. Now, that is not just any tick of an arterial symptom on your lower limb assessment form. It's you complete the lower limb assessment form, and is your whole picture showing acute or chronic limb-threatening ischemia? And in the video that you're watching, that's made clear, but I'm emphasising that point because we've already had one referral saying, oh, this person's got a red flag, so we can't put the 20 millimeters of mercury on. And the red flag was one mild arterial symptom, which was absolutely not representative of acute or chronic limb-threatening ischemia. So that person would have been suitable for the 20 millimeters of mercury. So make sure that you read what it says there. This video recording is going to go on our website on the videos tab. It'll also be on the bite-sized training. So if you need a refresh, you'll be able to go back and re-watch this video. Just to sort of update yourself, but bear in mind that it's acute or chronic limb-threatening ischemia. So that's the 3rd red flag. The 4th red flag is suspected acute DVT, and that's until you've got somebody anticoagulated and their pain manageable. So it may be only 24 hours or it may be a few days. And the other one is suspected skin cancer. Okay, so these red flags, if you're finding one of these red flags, the chances are you're going to need to onward refer somebody. So the blue box on the top right is about who you're onward referring to. So if the wound is below the malleolus, below the ankle bone, that's a wound on a foot. That should be referred to podiatry. So they would be the lead clinicians of a wound on a foot. So something like a necrotic heel, necrotic toes, something like that, you wouldn't need us. It would be between you and podiatry to be sorting out what you're doing with that foot. If you've got somebody with chronic edema, with a wound on the foot, or weeping toes, something like that, or you've got somebody with a venous element to their ulcer that you think requires compression, you're going to need all three of us. So podiatry need to know about the foot, but they shouldn't be taking it over fully, because if it's a wound on the foot secondary to chronic edema, what they need more than anything is compression. And we know that that's a tricky thing for podiatry to sort of be involved with. So sometimes it's going to be a teamwork affair of a wound on the foot. But podiatry should always be involved. If it's a diabetic with a wound on the foot, then that needs to be an urgent same-day referral to the diabetic podiatry clinic at Ocdem. You get your GP to do that and say, this diabetic's got a wound on the foot, they're not being seen anybody, can you do an urgent referral today to Ocdem, please, regardless of the symptoms. The acute or chronic ischemia is an urgent referral to vascular, and then more about that on the video to come, but also to us, because if you think this, you know, gosh, this is an awful arterial wound, you're probably still going to need a little bit of advice on how to manage the wound, etc., whilst you're waiting for vascular to see them. And obviously, if you've got suspected skin cancer, you're going to be asking your GP to refer to dermatology for a biopsy of that. So the red flags, if you find something, you need to look at the referral box as to who you'd be onward referring to. But if you've got none of those red flags, you're going to go straight ahead and you're going to put somebody into 20 millimeters of mercury. Now, you can do that in a number of different ways, depending on. We would recommend that if the person's got a uniform shaped leg and they'll fit inside a stocking and the wound isn't piddling fluid all over the place and a dressing would contain it, that you would get somebody into hosiery liners. Now, the current hosiery kit that we've got, the liners deliver 10 millimeters of mercury, so you'd need to have 2 liners on, and since they're not on halo, you'd need to order that anyway. So to start with, you're going to be using a bandage, and you need to know for the reduced compression, like you do for the full compression, what size your ankle circumference is to choose the right bandage. So 18 to 25 centimeters, the Coflex bandage is your 20 millimeters of mercury bandage. Above 25 centimeters, it's the K2 reduced larger size. You don't get the smaller size on halo, it's just the larger size anyway. So you'd be doing that immediately, but then you'll be putting in your and tell your patient that you're going to be Dopplering them and doing the full assessment within 2 weeks. And depending upon the results of that assessment, you'll either step up the bandage or you'll be putting a second stocking on top, actually be a third if you're using 2 liners. So warn them at the beginning that this is just they call this immediate and necessary care. So this is your first aid for the wound, if you like, but you have to do a full assessment to put the right full care plan in afterwards. So warn them how it's going to progress for them. So you'll be doing a Doppler and your holistic lower limb assessment and your full assessment of the wound, an assessment of their past medical history, lifestyle history, and not forgetting to map and photograph the wound. And I cannot emphasize how important the whole mapping thing is. I know we've all been hideously busy, that COVID's been a nightmare, and I know things are still bad out there, but it's really, really important to get this mapping done. I've had a patient recently that I looked at and I thought, oh, holy schmoly, what a cacophony of, what an awful collection of comorbidities and symptoms, and oh God, are we ever going to get this healed? And it's just looked like a right mess. And I've put my care plan in place and I think it's helping, but it wasn't until I mapped it, I thought, oh, goodness me, quite a bit of that has healed. And it was far further on than I expected. And actually, I needed to know that The nurses who are dressing the leg daily certainly need to know that it's getting somewhere, and so does the patient. Likewise, if you're not getting anywhere, you're wasting your time, and you need to have your eyes opened to it. It's very easy for person after person to go in and nobody to think, hang on a minute, is this really getting anywhere? Your eyes are deceptive. You know, mapping is the only way. Get a whole stack of those pens in your pockets, carry around some mapping stuff in your pocket, and get mapping those wounds, because you need to know exactly what's going on, or you're wasting your time. So this is the bottom half of the pathway. So it's all on one page. So there's a front and a back to it. So the pathway on the front and some more advice on the back. So after you've done your full assessment, when you come to assess the wound, you'll be using the TIMES framework. So on Julie Hewish's Wound Assessment and Management Study Day, you learn the TIMES assessment, where you look at the tissue type. As the first thing, is it slough, is it necrosis, and you put a plan in place for that. You try and identify if you've got inflammation or infection or even a biofilm present, and you'll be using the AMBLE 2 tool to help you identify that. You're looking at the moisture balance. You might be using the exudate pathway to help you work out what the right amount of exudate, what the right absorbent product is, but also the exudate will tell you quite a lot about whether you've got an infection. And you're going to be looking at the edges of the wound. You need nice sort of beach, they call them beaches and cliffs. We don't want cliffs to the edge of the wound because biofilm gathers around there. We want nice smooth edges, free of detritus, free of scabs, free of muck, free of dried exudate, not macerated, because it's only when you've got a decent wound edge can the cells divide and move in across the wound. So really important to get the edge of the wound in a good condition if you're ever going to get advancement and healing. And then you're going to be looking at the surrounding skin. If you think about the surrounding skin as being a breeding ground for things to crawl into the wound, you'll understand why it's really important to keep the surrounding skin clean. If you've got loads of hyperkeratosis on the skin around a wound, you know, as soon as you've turned your back and gone out the door, it's sliding off the skin into the wound bed and perpetuating wound bed infection and things for you. So keeping the surrounding skin clean and in good condition to prevent the wound from expanding or getting infected, vitally important. So you use your TIMES assessment, you look into the wound formulary, and there's a section at the front on wound categorization that helps you decide what your priorities are, what you're founding, what your priorities are, and what the dressings options are to do that. Couple of things in particular to mention about dressings on legs. One is we don't like adhesive dressings on legs. It's special needs skin. If you've got arterial disease, last thing you want to be doing is ripping that skin because the wound's not going to heal and you've got another ulcer. If you've got venous disease, chances are you've got irritable skin, you know, the whole varicose eczema side of things. You can cause more irritation and on the skin there. And this is why we've put the Cliniderm silicone border dressing on formulary, because under bandaging you'd be using pads and you'd be holding it in place with K-Soft and the bandages. Under a hosiery kit, that's a little bit more difficult. And if you've got only a low to moderately exuding wound, then the Cliniderm silicone border is a tacky silicone dressing, so it won't cause trauma to the skin on removal, and it also will fit underneath a stocking quite nicely. It also has the advantage of enabling the patient to deliver some self-care as well. So Cliniderm silicone border and no other adhesive dressings, please. The other thing is that if you've got an arterial wound on the leg and it's very sloughy, or you've got necrosis and things like that, you shouldn't be debriding wounds like that until you have established what the blood supply is, because if it's arterial disease and you try to debride it with honey and it gets all wet and soggy, the chances are it's just going to expand exponentially because there's not the blood supply to heal it. So you've got to be careful on debriding a wound where you might have arterial disease. You've got to get your lower limb assessment and your Doppler done before you try to debride. Word of note about this, we find a lot of wounds, and this is why we've included this on the pathway. A lot of the referrals that we get for wounds that aren't healing well or have deteriorated, we identify that they've got a wound bed infection, and it seems that, you know, lots of people out in the clinical world are not identifying that and not picking it up. It's your I would say it's your number one suspicion. If you've got somebody appropriately into compression and the like, and then the wound suddenly starts deteriorating, is getting bigger or is going nowhere, this is probably one of the first things you would think about. It's a massive culprit, having too many bacteria in the wound for preventing wounds from healing. So you really badly need to be using the Amble 2 tool. Again, on our website, to help you identify if you have a problem with bacteria in the wound. So you might have a local infection. Now these can be overt, so obvious. So you might look at it and go, whoo, that's red and screaming painful and green and there's pus dribbling everywhere. And it might be blatantly obvious you've got an infection there. But likewise, you might just have a wound that's a little dark in colour. There's no real erythema. It's a bit, you know, you've got some exudate and maybe slight odour, but nothing screaming at you in the face. That is probably a covert infection, and the Amble 2 tool helps you identify whether you have that. And then the spreading infection and the like. So strongly recommend that you're thinking about that and referring to the other guidance to identify if you've got a problem and also how to manage it. So you've done all of your assessment and you've come out with your ABPI. We're not taking ABPIs in isolation because you can get falsely elevated ABPI results. You always need to have your holistic lower limb assessment done as well. Are the two telling the same story? If you're happy that they are, then you put them into one of these sort of categories. So if you've got an ABPI less than 0.6 and you're happy that that's accurate because it fits with your lower limb assessment, that's an arterial wound. You wouldn't be putting compression on that, and you'd be referring urgently to vascular, or getting a GP to refer urgently to vascular, and you'd be referring to us for some advice of what to do in the interim period. ABPI 0.6 to 0.8. We would call that mixed disease, so element of venous and arterial, and somebody suitable for reduced compression at 20 millimeters of mercury. It's still some arterial disease, so they still need referring to vascular, but it's not urgent. And then 0.8 to 1.3, this is we would say is suitable for full compression, and they should be having 40 millimeters of mercury there. Now, if this is a venous ulcer, if you can see venous disease on the legs, then you should be referring them to vascular for a venous duplex scan and possible sclerotherapy, as I was saying. And then if you've got an ABPI above 1.3, that could be calcification of the arteries, hardening of the arteries. It's arterial disease. Refer to us and we can decide whether it's still safe to put a bit of compression on, because if you've got edema in the leg, for sure you need it, and whether it's suitable for referral to vascular as well. So you're referring to vascular for virtually any patient, I think, with a wound on the leg, aren't you? At the same time as diagnosing those, you'd be examining somebody to see if they've got any chronic edema. The compression guidance and some of the other things you need to think about when somebody has chronic edema are all detailed on the chronic edema pathway. So you'd need to refer to that if they have edema as well. So on the back of the form, we'll go on to that in a minute, is the advice about what are the bandages options for each of those categories. And when you've put your plan in place and you've selected your appropriate bandage, what you're supposed to be doing is, oh, I've got the old one on here, right? Yeah, somebody spotted a bit of a typo. So it will say reassess the wound every 4 to 6 weeks, not every 4 weeks. The biofilm pathway says every 6 weeks. And when we advise mapping and making the calculation of, has there been 40% reduction, that's over a 6-week period. Now, the National Wound Care Strategy is saying we should be reviewing leg ulcers every 4 weeks, but we thought we were going to be confusing you guys if we got you to review it every 4 weeks and map it every 6 weeks, whatever. So 4 to 6 weeks, and you're looking for 40% reduction in ulcer size over 6 weeks. If when you've done your reassessment, you haven't had that reduction, you need to think why. If you can explain it, the patient went into hospital and took the compression off. There's been a bout of really hot weather, so they took the top layer of bandaging off. They've had a wound infection, or they're very anemic, or something like that. If you can identify why, and you know why it is, and you're rectifying it, that's fine. But if you can't work out why your wound hasn't progressed at that level in 6 weeks, then you need us, and you need to refer to us so that we can help work out what is preventing this wound from healing. So, you know, the sooner you get that done and the sooner get us involved, the greater chances we have of getting this healed quicker, and not dragging on for weeks. Regardless, if your wound is still there after 12 weeks of treatment, you should be referring to us. And once the leg ulceration has healed, you're going to need to be considering maintenance compression. So those are your sort of kind of reviewing guidance. So this is what's on the back of the pathway. So if after your assessment you decide the patient should be in full compression, these are your options. So your first line option, we would say, would be a hosiery kit. You can use a hosiery kit. Hosiery kit is a box that comes with, show you that in a minute, with 2 stockings, a liner and a top one. And that's appropriate if you've got a good anatomical shape and you haven't got too much exudate. If you have, then you're probably going to need compression bandages if it's wet or a different shape. Generally speaking, Actico if somebody's mobile and has got calf muscle pump activity. So shuffling and not going heel to toe walking still isn't calf muscle pump activity. So Actico is great when people are mobile because it really gets the pump muscle action going. If you've got an ankle above 25 centimetres, you then have to have the second 10 centimetre bandage from the ankle up of that. You can be using K2 if somebody's mobile. It's good for people who are less mobile. If you haven't got a lot of calf muscle pump activity, the long stretch element of the bandage puts compression on all of the time. So there's no black and white rule on this, and there may be reasons why you would choose one over the other, but generally your initial decision making would be based on somebody's right level of mobility. You just need to be really careful that you get the right size K2 for the right ankle size. Every patient with a wound on the leg needs a tape measure in the house so that you can be checking that ankle size after you've put wool on every single time, making sure that you've got the right level of compression. You also need to make sure that you're shaping that leg so the narrowest bit of the ankle is at least 8 to 10 centimetres smaller than the widest bit of the calf. If you've got an up and down drain pipe, nothing's going to go anywhere, and God forbid the ankle's wider than the top of the leg when your compression would just be tourniqueting. So please pay lots of attention to how you're shaping, get those tape measures out there, make sure you're using the right bandage. Reduced compression, as we said at the beginning, 2 liners would deliver 20 millimetres of mercury in the L&R range of Activa or Actilymph. If you're going for second line compression bandages, it's the Coflex or the K2 reduced, depending on the ankle size. And if you've got chronic edema, your first line bandage would be double layer of Actico with 8 centimetres to the foot and ankle, 10 centimetre below the knee. And if it's thigh high, you'd be going up to 12 centimetre bandage. Second line bandaging compression for chronic edema, we have Coban 2 on formulary now, and that's only for use for very misshapen legs and for thigh high bandaging where the Actico isn't sort of feasible. You can only get that through us. What I would say is you may know as well that we now have wrap garments on formulary. They are not intended for use with active ulceration. They're not there to heal leg ulceration, and that's because we haven't got the evidence base for that yet. It may well be, you know, a hosiery, we've got excellent evidence to prove that hosiery kits heal ulcers just as well as bandaging, but actually people can fiddle with wraps. They can take the tension off. Maybe people don't put enough tension on to start with, and it may be that those factors mean that they don't heal wounds quite as well as bandaging and the like. So not using a wrap for use with leg ulceration, but where the wraps do come in is in maintenance compression. So first line would still be hosiery. A good fitting stocking and made to measure stocking, in my mind, is better in most circumstances than anything else. However, the wrap garments are another tool in your toolbox because getting people to concord with compression can be quite tricky. And we've got 2 wraps there. There's either the Faro 4000 for no edema, any edema, you want the Juzo ACS Lite, and further information about those is available now. We've updated the hosiery formulary so that it's now called the hosiery and wrap formulary, and details about those wraps are available on that, and that is on our website. On the lower limb tab, scroll down to the compression section and you'll find that there. So just a little bit more of a word about hosiery kits. We have 2 hosiery kits on formulary. So what a kit is, they come in a box like this, and there's 2 different sorts of stocking in there. So there are 2 liners, which can be white, or they can be beige, or they can be black, I think. But they're a different colour to the stocking, and they're closed toe. And the liners deliver 10 millimetres of mercury. So if you're using them as your first for immediate and necessary care, you'd need to use the 2, but 1 liner and then the other compression stocking that's in the box adds up to around your 40 millimetres of mercury, which is the same as your full compression bandage. So we've got 2 hosiery kits because one is suitable for legs without edema. This is softer and more conformable, and that's the British Standard hosiery kit, the Activa leg ulcer hosiery kit. And then the Acti-Lymph hosiery kit is for limbs that have got edema, and it's a stiffer fabric to try and help stiffen that edema. Yes, if you've got somebody that fits the off the peg stuff, then that is absolutely ideal. Okay, so I'm going to stop sharing the slideshow now, and I'm going to just play you a video.
Hi, my name is Leanne Atkin. I'm a vascular nurse consultant from Mid York's NHS Trust, and I'm here to talk about the immediate and necessary care of lower limb wounds. Many of you will be aware of the National Wound Care Strategy Programme, which got published now around 12 to 18 months ago. And actually, this highlights the need for change when we're dealing with patients with lower limb wounds. The National Wound Care Strategy highlights that there is a number of variations in the care that we deliver, and this provides the NHS an opportunity to reduce spend, an opportunity to reduce the burden, but also an opportunity to improve the management of patients and therefore reduce patient suffering. The National Wound Care Strategy provides clear recommendations in terms of how to care for a patient with a lower limb wound. But today's session is going to focus on that immediate and necessary care, as actually this is the bit that's been rather groundbreaking in the way that we are now managing lower limb wounds. So the first thing that the National Wound Care Strategy asks you to do is to assess for the red flags. And this is part of the immediate and necessary care. So this should be delivered by every practitioner. Doesn't matter who you are, what role you have. If that person presents to you with a lower limb wound, this is what you should be doing. And those red flags is about really trying to tease out, does that patient require urgent escalation to other services? So I just want to spend a few moments with you explaining and helping you recognise each one of these red flags. So the first red flag that the National Wound Care Strategy asks you to assess for is whether there is any acute infection on the leg or the foot. And the reason for this is that we really need to tease out any patients with active acute cellulitis or patients with foot ulceration with infection, especially diabetic patients. So actually the first red flag asks you to assess for any systemic features of infection, such as a raised temperature, a raised pulse, tachycardia, the patient feeling generally unwell, complaining of flu-like symptoms or a general malaise. These can be signs of a systemic infection. And then it's actually about focusing on the leg, thinking about whether there is any evidence of local infection. So thinking about, is there any evidence of redness, erythema around the wound margin or spreading up the limb? Often, if it is infective, there will be a clear demarcation between the normal looking skin and the inflamed skin. When you're thinking about cellulitis, you're looking at the wider part of the leg, looking if there is any changes in terms of the skin shape and size. And I say that in terms of its shape because it can start to look more like orange peel. As the subcutaneous tissue starts to get more inflamed, you actually get puckering from the hair follicles down into the dermis, so you get this like orange peel effect, and that can be a classic sign of having cellulitis. For many types of infection, that the patient will be expressing pain, which is worse actually on palpation or movement of that tissue. But just be careful with the diabetic patient, because obviously their pain mechanism can be depleted because of their underlying neuropathy. It's about thinking, does that foot or that leg feel hot to touch? With infection, you often get heat. You get that edema, which makes the tissue look glossy, and actually you get an elimination of fine lines, and occasionally you can get blistering surrounding the wound. Or if you've got any presence of pus that's happening or discharging from the wound, especially if a patient that's got foot wounds, you need to be thinking about, is there any evidence of acute infection of the leg or the foot? And this is where you need to be referring those patients urgently back to their healthcare practitioner, that being their general practitioner, or if you're unable to get hold of that, that's escalating it further, because actually acute infection is a medical emergency. And the reason why it is a medical emergency, it links back to the next red flag, because actually what we need you to do is to screen for signs of sepsis, because sepsis remains the #1 killer of patients out there, and this is preventable, is that death. So it's about screening your patients for sepsis, thinking about those wider systemic responses. If that patient is reporting confusion, slurred speech, or is simply not making sense, think about that infection. If the patient's becoming more sleepy or difficult to rouse, again, it can be a sign of sepsis. You often find that patients, as they go through the sepsis, become relatively pale around the lips or around their fingers as it starts to impact on the oxygenation of the tissue. If your patient's got difficulty breathing, an elevated, substantially elevated temperature, pulse or respiration, an increasing breathlessness, you need to be thinking of sepsis. And if you have any signs of sepsis, this is an acute emergency and the patient needs to be directed to an accident and emergency department. So there are your two main signs, and actually presence of infection and sepsis can happen and does happen within the management of wound care. But the third red flag is actually looking for you to assess if a patient's got acute or chronic limb-threatening ischemia. Let me reassure you that acute ischemia, sudden onset limb ischemia, is very rare indeed. You're probably not going to see that within your professional career. So if an acute ischemia patient would report a sudden onset of terrible pain, mottling of their skin, and that patient does need to be directed to accident and emergency. But like I said, that is rare. The other side of that, though, is chronic limb-threatening ischemia. So where we've got a reduction of the blood supply in the foot that's happened over a number of weeks. And that patient can develop arterial rest pain or gangrene of the toes, such as seen within these pictures. This isn't sudden onset. This has developed over a period of time and is often associated with severe pain, especially on a night time. But again, beware of your diabetic patients who may well be masking that pain. If patients are showing any signs of tissue loss on their feet, especially any areas of black gangrene, those patients need to be screened out for critical limb ischemia. This is not a medical emergency as such. The patient doesn't need to go to A&E today, but that patient certainly requires an urgent referral to the vascular team, and that patient should be seen within a matter of days. We try to ensure that patients are revascularised within a target time frame of 14 days. So if we need these patients referring to us as soon as possible. So there's no need for an acute admission, but certainly a need for acute escalation. So that's the third red flag to watch out for. The fourth red flag that the National Wound Care Strategy asks you to assess for is whether you've got any suspicious of an underlying deep vein thrombosis. Within a deep vein thrombosis, the initial signs is often unilateral limb congestion or swelling, one leg. If you've got bilateral limb swelling, the chance of you having a deep vein thrombosis is very small indeed. The patients will often describe its sudden onset within the last 12 hours. 12 hours ago, my leg felt fine. I've woke up this morning. It's terribly painful, it's terribly swollen, and it's terribly inflamed. Patients often report that they have increased pain when flexing or extending the ankle joint. You can have some red or purple discoloration on the back of your leg, and it can be warmer to touch. But for me, when I'm thinking about as a patient got a potential to have a DVT, it's actually asking about that patient what's been happening over the last 2 weeks. Have they had an operation where they've been immobilised, which has increased their risk of having a DVT? Are they currently wearing a cast on the other leg, which again has impacted on their mobility? Have they got underlying thrombotic disorders or an underlying cancer, which makes them more likely to develop a DVT? And finally, has a patient been on a long haul flight? But actually, the evidence about long haul flights and developing DVT is getting weaker as the years go on. But it's about thinking about, has there been a recent change in that patient's mobility that could have increased that patient's susceptibility to develop a DVT? And then the final red flag is talking about if that patient has got suspected skin cancer. There's still many basal cell carcinomas and squamous cell carcinomas on the lower leg, which we are missing. So if a patient reports a blemish or a mark on their leg that's changed over time, that's often itchy, it heals but then it bleeds again, have a suspicious in your mind about whether this could be an underlying skin cancer. Some patients report them being slightly painful, but most patients say they're tender and itchy. I think we all need to slightly reduce our tolerance of undertaking a wound biopsy, because actually that's the ultimate way that we can exclude any form of skin cancers. So they are your red flags. That's what the National Wound Care Strategy asks every clinician to assess for. And then following that, the National Wound Care Strategy finally gives a clear definition of what is a foot wound and what is a leg wound. They've actually drawn a line in the sand that links from the top of the foot round to the lateral malleolus. And you can now have clear recommendations in terms of whether that patient needs referring to a podiatrist or a wound nurse. So when we talk about the immediate and necessary care, it's about assessing for those red flags, but then actually it's about delivering some form of here and now wound care. What we've done is actually we've bring cleansing back. We need to ensure that we are cleansing the wound and the surrounding tissue with the most appropriate factor. We need to be putting on a dressing that's low adherent, that's not going to stick, but something with sufficient absorbency to control that level of exudate. But actually, the thing that's really groundbreaking from the National Wound Care Strategy is that we're now saying apply 20 millimetres of mercury pressure here and now, only on the exclusion of the red flags. There's no need to palpate pulses or to arrange an ABPI. We need to be putting on 20 millimetres of mercury straight after our red flag assessment. And that's because we think, and the National Wound Care Strategy supports the fact that actually this compression can do very little harm. In fact, so long as you've screened out for your critical limb ischemias or other detrimental factors, that actually this compression can aid healing and therefore prevent that wound from deteriorating. So think about this as first aid for legs. So you need to think about within your practice of how you can deliver 20 milligrams of mercury pressure, and there's a number of ways to do that. And the reason why the National Wound Care Strategy is asking that is the fact that we need to be treating these patients sooner in the pathway. For every chronic wound that we are dealing with out there started as a small simple ulcer, and if we were able to get their first aid compression right from the moment that they ulcerated, there is a chance that we could actually reduce the amount of chronic ulceration that the NHS is currently dealing with. The immediate and necessary care also highlights the need for onward referral. So it does clearly state that if you have a patient with a wound on their foot, they should be referred within 1 day to a multidisciplinary team. If you have a patient with a wound on their leg, there is 14 days from original presentation for you to complete that full holistic assessment, that ABPI, that underlying diagnosis. So we've tried to shorten the timeframes to really focus on that accurate diagnosis as soon as possible. The evidence base is relatively clear. We know how to heal a patient with a venous leg ulcer. And what we're trying to do with the National Wound Care Strategy is ensure that the evidence base is available to the patients there and then. And the major thing is about getting that patient into that strong compression as soon as possible. And that's why that 14-day challenge has been given, so we can get those patients into strong compression as soon as we can, because that is the best way to help manage a patient with a venous leg ulcer. We need to review these venous leg ulcers and think about them as a weed. We need to be thinking about that underlying venous hypertension, and the only way we can manage that is actually through strong compression. So we need to be thinking and changing our opinion of that venous leg ulcer. We need to not think about it as a wound on a lower leg. We actually need to think about it as a weed. What you're seeing is basically the head of the weed. We need to treat the underlying venous system, and we need to do that as soon as possible with strong compression. So hopefully this session has given you the requirements of what immediate and necessary care involves, and given you now the underlying knowledge and the confidence to be able to assess the red flags for your patients, and therefore start that mild compression as soon as you can. Thank you for watching.
So Gabby and I have worked together to alter this document, which I'm sure is hugely familiar to you. So nothing has changed on the foot about you identifying what wound it is, from your full assessment, what factors will delay healing. But this bit is a little bit different on the back. So where with the lower limb assessment, previously there used to be a chart here, a table with arterial symptoms and venous symptoms, and you were required to tick all of the ones that were there. And this was meant to, for clinicians that were very familiar with the holistic lower limb assessment form, meant to shorten down that assessment sort of process for you. What we found was that people were still using the holistic lower limb assessment form, the sort of the landscape document with the descriptions of what you need to do and the rationale behind it to identify arterial and venous disease, and that they weren't completing the arterial and venous symptoms assessments very well. We would see patients and go, well, I can spot at least another 4 of these symptoms that are on this leg. Why haven't these been ticked? So it seemed to be that you were favouring the holistic lower limb assessment form, and we have updated that to make it a bit more useful for you. We've put the clinical examination into those 3 sections of arterial symptoms, venous symptoms and chronic edema, and then we have the same box on the bottom of that form as you've got here. So you'll do your holistic lower limb assessment on the separate form, and then your findings from that, you'll plug your brain in at the end of it and go, right, what does all of this mean? What does the Doppler mean? What's the assessment showing? What are my conclusions? Have I got arterial symptoms, venous symptoms, chronic edema? You summarise them by ticking these and making comments here as to what the outcome of your holistic lower limb assessment is. This bit here is for even before that, this is your red flags bit. So getting rid of that table and moving on to you reusing the holistic lower limb assessment form has left us some space on your form to now put your red flag assessment in here. So when you see a patient for the first time, you need to identify each of these columns needs to be ticked. It's either present or it's absent. There's nothing in between, and there's nothing just not there. So this is your accountability for your red flag assessment by ticking these boxes here to say, yes, I've assessed, they're present or absent. And if you've got no red flags, then you will of course be putting your 20 millimeters of mercury on. Your full assessment 2 weeks later, you'll have the outcomes of your lower limb assessment, and then your Doppler readings down here, and the conclusions you've come to about what the etiology. All right, guys, please do spread the news far and wide. I'm particularly concerned that everybody understands that red flag assessment and watches that video. So I'll get this video on the Bite Size channel and onto our website as soon as possible.